Osteoarthritis is a long-term joint disease that happens when the smooth cartilage that protects the bone wears down. This causes joint pain, stiffness, swelling, and difficulty to moving. It is usually related to aging and past injury, too much stress on the joint, or family history. Over time, it can damage not only the cartilage but also the bones, ligaments, and joint lining, which may lead to joint deformity and loss of function. In this case study, the patient is a male with grade 4 osteoarthritis in his right knee. He experienced severe pain, stiffness, and trouble moving because the cartilage was completely worn away. The joint space became narrow, the bone became harder, and the bone spurs, which is the extra bone growth, formed. To reduce pain and improve movement, the patient needed a right total knee replacement, which is TKR. Chow Pek Muang, a 70-year-old Chinese Chow male from Rejang Park, Cebu, is a Roman Catholic and a pensioner. Fluent in Malay, Mandarin, and English, he was admitted to Hospital Cebu on 12 August 2025 due to right knee pain. Currently, he is stable and actively participates in daily activities. Chow is a non-smoker, non-alcoholic, and non-allergy patient and maintaining a normal appetite. And next, chief complaints. On 13 August 2025, he was referred to Hospital Cebu for a right knee replacement due to pain. He had previously undergone a total left knee replacement on 23 April 2025, which was successful and improved without complication. After 6 days, the patient was discharged and his left knee can now bend to 90%. However, after the right knee operation, he lost a significant amount of blood, which was 290 cc, requiring a blood transfusion. The patient's knee pain is due to his old age and causing difficulty walking and standing. For medical diagnosis, this patient, 70 years old with grade 4 severe osteoarthritis with the presence of osteophytes of the right knee, underwent a right total knee replacement TKR due to persistent pain, stiffness, and functional limitation. This indicating advanced joint degeneration with significant loss of cartilage, joint space narrowing, and bony overgrowth. The knee's cartilage is almost completely worn away, causing bones to grind against each other. The surgery aims to restore joint function, relieve the pain, and improve the mobility despite the conservative management ineffectiveness. For his past health history, the patient underwent a total left knee replacement in 23 April 2025, demonstrating good progress without any complication. He is now able to flex his knee up to 90%. The patient has a history of prostate problem and hypertension. He also underwent the right eye cataract surgery several years ago, resulting in a significant vision improvement.
Hello, my name is Nurul Shakira, and I'll be presenting our patient physical assessment. On general assessment, the patient was alert, cooperative, and was in mild pain. Vital signs were stable and febrile, with clear breath sounds, normal heart sounds, and a soft, non-tender abdomen. The skin appeared warm, pink, and intact. Peripheral vascular assessment showed capillary refill less than 2 seconds, and no edema or signs of deep vein thrombosis. Focusing on the musculoskeletal assessment, inspection of the knee incision site, the right knee had slight redness and swelling and some drainage, while the left knee was completely healed. The alignment was normal, where the legs are straight, aligned with the hips and ankles. And then on palpation, there are some swelling around the knee joints and also tenderness, while the left knee showed no tenderness and no abnormal findings. For range of motion, the right knee could not extend or flex, and the right hip only showed slight flexion with no extension possible. In contrast, the left knee had full range of motion.
For lab and diagnostic tests, the patient had full blood count. His pre-operation day was on 12th of August. During that time, his hemoglobin levels were still at the normal range, which is 12.4 gram per deciliter. And then he undergone a total knee replacement operation on 13th of August. And it is during that time that his hemoglobin levels had dropped, which is 9.8 gram per deciliter, which is a significant drop from 12.4 to 9.8, because he had lost a lot of blood during the surgery. And then he received 1 pint of PEG cell transfusion on 14th of August, and his hemoglobin levels remain 9.9 from 14th of August until 15th of August. Now I will explain the disease process of osteoarthritis. Osteoarthritis is a progressive breakdown of the protective cartilage. The contributing factors are mechanical stress due to overuse of the joints, for example weightlifting, and also obesity because of stress overload to the joints. It can also be due to injury to the joint and also due to aging. So the process begins with changes to the cartilage, where the cartilage begins to degenerate. During the early stage, the surface of the cartilage become uneven and rough, which leads to irregularities, and this is called fibrillation. As it progresses, small areas of damage called erosion spread to the bone underneath of the joint. In osteoarthritis, chondrocytes or cartilage cells, they release more catabolic enzymes as a response. For example, the enzyme matrix metalloproteinase. The enzymes will digest proteoglycans and collagen, which provides lubrication and strength. And when the cartilage cells release more catabolic enzyme, they will digest more and more proteoglycans and collagen, which is important for lubrication and strength. So in essence, this does more breakdown and damage than repairing, which leads to swelling and damage to the joint. As the cartilage wears away, the bone begins to remodel itself. So the bone under the cartilage, called the subchondral bone, begins to thicken, and this is called sclerosis. Other than that, there will be also formation of osteophytes, or known as bone spurs, and these are essentially outgrowths of new cartilage at the joint edges, and these new outgrowths will harden or ossify into a bone. After bone remodeling, the synovium, which is the lining of the joint, becomes inflamed. In a normal joint, the synovium release or makes synovial fluid to reduce friction. But in osteoarthritis, the synovium becomes swollen and inflamed. And as a response, the immune cell will move in and multiply at the site. And the immune cell will release more inflammatory chemicals, and these inflammatory chemicals will tell the chondrocytes to release more enzymes. And these enzymes will do more cartilage damage because they digest proteoglycans and also collagen. So it is a loop which leads to progressive damage to the joint. So the joint capsule becomes stretched, swollen, and stiff, and calcium crystals will also be released during late osteoarthritis, causing inflammation and pain.
Now, I will explain the management of our patient through a surgical procedure, which is called total knee replacement, or TKR. TKR is a surgical procedure where the damaged knee joint is replaced with a new metal and plastic implants. The aim is to restore the alignment and function of the knee. There are 4 basic steps in this procedure. First, the bone is prepared. The surgeon removes the damaged cartilage surfaces at the ends of the femur and tibia, together with a small part of the bone underneath. Second, metal implants are positioned. These metal components replace the removed bone and cartilage, recreating the joint surface. They may be cemented or press-fitted into the bone. Third, the patella or kneecap may be resurfaced. The undersurface is cut and replaced with a plastic button, but sometimes this step is skipped depending on the patient's condition. Finally, a spacer is inserted. This is a medical-grade plastic piece placed between the metal components to allow smooth movement of the joint. Total knee replacement is mainly indicated for patients with severe osteoarthritis who experience persistent pain, stiffness, and reduced mobility that are not relieved by conservative treatments. In our case, the patient has grade 4 osteoarthritis with osteophyte formation. The overall goal of the surgery is to restore function, relieve pain, and ultimately improve the patient's quality of life. Next, I will explain about the pre-surgery management for our patient. The first part is medical optimization. The patient's hypertension must be controlled with regular antihypertensive medications to reduce both intraoperative and postoperative risk. Since the patient also has a mild prostate condition, this needs to be monitored closely to anticipate the possibility of urinary retention after surgery. In addition, a blood count should be assessed to detect anemia. If needed, cross-matched blood should be prepared in advance to ensure availability for transfusion during or after the operation. The second part is to perform imaging tests of the affected knee. An X-ray or MRI is essential to visualize the extent of joint damage and to help the surgical team decide on the most appropriate surgical approach for the patient. The third step is patient education. The nurse should explain the surgical procedure of total knee replacement, including its purpose and possible complications, so that the patient has a clear understanding. The patient should also be taught how to use assistive devices such as a walker or cane to prevent falls and promote safe mobilization after surgery. In addition, it is important to introduce the role of physiotherapy, which will help the patient restore joint mobility and function after the operation. The fourth step is pre-operative nursing care. This includes obtaining baseline vital signs and pain score to provide a reference for post-operative monitoring. The nurse must also ensure the patient is kept NPO or nothing by mouth or for 6 to 8 hours prior to anesthesia to reduce the risk of aspiration. It is equally important to confirm that the informed consent form has been signed and that the patient fully understands the procedure. Lastly, the nurse should provide psychological support to help reduce anxiety and prepare the patient mentally for surgery. Next, I will talk about the management of the patient after surgery. The first aspect is wound care. After a total knee replacement, the surgical site needs very close monitoring to prevent infection. The incision is usually closed with sutures or staples, and some drainage is normal in the first few days. The nurse should inspect the wound regularly, looking at the dressing for any leakage. It is important to note the color consistency and amount of drainage. If a drain is inserted, the output must be measured. Clear or slightly blood-thin drainage can be expected, but the presence of pus may indicate infection and must be reported immediately. Maintaining strict aseptic technique during dressing changes is essential to protect the wound. The second aspect is pain management. After this type of surgery, the patient often experiences moderate to severe pain, which can interfere with mobilization and recovery if not managed properly. Analgesics, both oral and intravenous, should be administered as prescribed to maintain the pain score below 5. In addition to medication, non-pharmacological measures are important. The operated knee should be elevated above the level of the heart to promote venous return and reduce swelling. Cold therapies such as ice packs or cooling pads may also be applied to decrease pain and inflammation. Educating the patient on relaxation techniques such as slow breathing can also help in managing discomfort. The third aspect is to monitor for complications. Nurses should perform regular neurovascular checks on the operated leg. This includes assessing the color, temperature, pulses, capillary refill, sensation, and movement. Any signs of numbness, tingling, or diminished pulses should be reported immediately as they may indicate compromised circulation or nerve injury. The wound should also be checked for signs of infection such as increasing redness, swelling, warmth, pus, or excessive bleeding. Monitoring drain output is equally important as sudden changes can be an early sign of complication. Systemic symptoms like fever or chills should also raise concern for possible infection.
Next is the outcome. The first one is the wound care. Patient surgical wound remains clean, dry and intact with no sign of infection. And then the second one is the pain management. Patient reports reduction in knee pain to tolerable level after anesthesia, which is the celecoxib, and the pain score reduced from 5 to 2 out of 10. And the third one is to monitoring the patient blood drain from the side, which is there is no sign of excessive bleeding or any infection, which the drain output gradually decreases to less than 50 ml within 48 to 72 hours. And then the last one, encouraging the patient to ambulate, which is the patient gradually regains mobility with physiotherapy support and walking assistive device without pain and any diseases.
The care for this patient was not terminated immediately but was still ongoing until the patient was safe to discharge. Plan of care for this patient was transition slowly. So the reason for transition, first, the patient's vital signs were stable post-operation, but his drain output was still high and patient's hemoglobin levels had a significant drop from 12.9 gram per deciliter to 9.8 gram per deciliter. So the doctors have prescribed him with 1 pint of PEG cell transfusion. His surgical wound was assessed and the wound was clean and intact, and the patient was able to ambulate short distances with assistive device and physiotherapy support. So he was improving in terms of his ambulation. For his continuity of care, the patient was referred to physiotherapy for ongoing rehabilitation and functional recovery. Patient was advised to continue follow-up with the orthopedic clinic for wound review and implant monitoring. The family members were also educated on wound observation, safe ambulation, and also thrombosis prevention.
Next, nursing progress. The patient underwent left TKR on 23 April and the right TKR on 13 August. The left knee showed good progress with mobility up to 90-degree deflection and improved function after 4 months. Right knee post-operative condition less stable, noted intraoperative blood loss with 290cc drain and 1 pint PRC, packed red blood cell transfused. Patient also currently reports pain score 5 out of 10 at right knee and left leg are able to move side to side and lift without difficulty, while right leg show reduced mobility. Both ankles and toes mobiles, hips move except right side due to the knee pain. And patient has underlying hypertension and overall recovery satisfactory on left leg, while the right knee requires close monitoring for pain management and post-operative progress.
Moving on to our nursing care plan, for our first prioritized nursing diagnosis, acute pain related to surgical incision, as evidenced by patient reporting pain score of 5 over 10 upon moving the affected limb. So the short-term goal for this patient, within 24 hours, the patient will report decreased pain score from 5 over 10 to a manageable level of 2 over 10.
The interventions included assessing the pain level using a pain score scale to guide treatment objectively, administering analgesics prescribed by the doctors, such as paracetamol or tramadol to reduce pain and promote mobility, and encouraging some relaxation techniques such as looking out the window or listening to music for comfort. We can also apply ice packs to control the swelling, then explain the importance of reporting worsening or unrelieving pain, and provided emotional support to help the patient cope positively.
Upon evaluation, after 24 hours of nursing intervention, the patient was able to report that pain has relieved and decreased to a pain score of 2 over 10.
Okay, let's move on to the second prioritized nursing diagnosis, which is impaired physical mobility related to pain and surgical procedure on right knee, as evidenced by patient reporting pain 5 over 10 on movement and limited range of motion post-operation. So, for the goal for this nursing diagnosis, within 48 hours, patient will verbalize decreased pain during movement and will demonstrate use of assistive devices such as walker, crutches correctly. So, the nursing intervention, number 1 is the assessment level by using pain score scale 1 until 10. So the rationale behind this action is, as a nurse, we need to evaluate the effectiveness of pain management intervention. The second one is to administer prescribed analgesic such as NSAIDs, opioids. So this rationale is the adequate pain control according to the severity of the pain. So the number three, as a nurse, we need to encourage active and passive range of motion exercise for unaffected limbs for patient. So this is to prevent the contracture and muscle stiffness. Number four, as a nurse, we need to assist patient to ambulate using walker or crutches safely. So this session is to promote the circulation and healing and encourage patient to carry activity daily livings. So the number five is to maintain proper positioning of the operated knee, such as like use the pillow or knee immobilizer if ordered. So this intervention is to promote bone healing properly and prevent bone deformities during the healing process. So the last one is to ensure safe environment at work setting with a good lighting. This is for reduced risk of falls at work setting when the patient ambulate using the walker or the crutches. So the evaluation is within 40 hours of nursing interventions, the patient was able to verbalize decreased pain upon movement and demonstrated the correct use of assistive devices such as walker or crutches. Okay, let's move on to the third prioritized nursing diagnosis. So it is the risk for deficient volume fluid as evidenced by high urine output 290 cc and hemoglobin drop from 12.4 gram deciliter to 9.8 gram per deciliter. So the short-term goal for this nursing diagnosis is within 40 hours, patient will demonstrate no signs of hypovolemic shock and will no signs of dehydration. So the number one for nursing intervention is monitoring vital signs and signs of hypovolemic shock, such as BP, pulse rate, dizziness, and pallor. So this is provide the baseline data that may indicate hypovolemia. The second one is to measure and record urine output, noting amount, the color, and the consistency of the drainage. So this is for identify abnormal bleeding and indicate worsening of blood loss. Number three is the monitoring intake and output, including urine output, the amount, the consistency, the urine color, and also the number of bowel open. So this is for the detect early signs of dehydration, such as urine output and urine concentrated. Number four, positioning patient with leg slightly elevated. So the rationale behind this action is to promote venous return and maintain the blood pressure. The number five, as a nurse, we need to maintain the IV access and administer prescribed IV fluid or blood products as ordered by the doctor. So this session is for prevent dehydration and hypovolemic shock by placement of IV fluids and blood products at the emergency moment. And then the last one for the nursing intervention is educate patient to report symptoms such as dizziness, palpitation, and weakness. So the rationale behind this is early detection of worsening hypovolemia by patient involvement regarding on health. So it will help the nurse to provide the care earlier in maintain their condition. So the evaluation for this nursing diagnosis, after 40 hours of nursing interventions, patient was able to demonstrate no signs of hypovolemic shock and no noted signs of dehydration. Okay, let's move on to the medication part. So the first medication that patient take is the IV furosemide state 20 mg. So this route classification is the alternative that giving by the road intravenous. So the indication for this patient, IV furosemide is given to reduce the edema due to heart failure, liver cirrhosis, or renal disease, and also it can manage the hypertension. As a nurse, nursing responsibilities such as monitor blood pressure and signs of dehydration, and also assess the kidney function such as bun and also the creatinine. So the second one is the tablet zinc copper, 1 tablet OD. So the drug classification is the iron supplement or hematine. So this is given by oral that indicate for this patient is to treat and prevent iron deficiency anemia, and also the general supplement for folic acid and zinc. So as a nurse, nursing consideration is such as check for sign of iron deficiency that we can detect by the patient's patient appearance by the fatigue and also pallor, and also advised for patient to avoid taking with milk, tea, or coffee that may reduce the absorption of the zinc. Okay, to continue, the medication that patient take is the tablet calcium carbonate 500 mg for BD twice a day. So this drug classification is the calcium supplement or antacid. This medication is given by orally, and the indication for this medication is to treat and prevent osteoporosis and also calcium deficiency, and it also can relieve heartburn and indigestion. So as a nurse, the nursing consideration is to monitor signs of hypercalcemia and also encourage adequate fluid intake to reduce risk of kidney stone. And then the fourth one is the tablet trazodone 5 mg once per day. So this drug classification is the alpha-1 adrenergic antagonist that is will given orally. So the indication for this medication is for the treat hypertension by the vasodilation, and also the treat the underlying disease that patient have, such as benign prostatic hyperplasia (BPH). So as a nursing consideration, we will assess the urinary symptoms such as nocturia, frequency, and the flow, and also monitoring blood pressure regularly, which leads to hypertension that affect by the vasodilation. Okay, the last step for the medication, the patient take capsule celecoxib 200 mg twice a day. So this drug classification is as non-steroidal anti-inflammatory drugs instead. So this medication is given by oral. So the indication for this medication is for pain relief and improve mobility in osteoarthritis cases, especially for this patient, and also it will help patient in reducing inflammation, joint stiffness, and also the pain. So nursing consideration for this medication, as a nurse, we need to encourage adequate fluid intake to protect the kidney, and monitoring blood pressure as celecoxib can cause hypertension. So the last one is the IV cefuroxime 1.5 gram TDS. So the drug classification is second generation cephalosporin beta-lactam antibiotic. So this medication is given by intravenous. So this indication for medication is for prevent the post-operative surgical prophylaxis that patient have undergo total knee replacement procedure, and also it will help the prevent the bone and joints infections during the healing time. So the nursing consideration for these drugs, that as a nurse we need to monitor surgical wound healing and signs of infection, especially at the incision site that may show the sign of infection such as swelling, the hyperthermia, and also for the redness. And then the last one is the assess for allergy to penicillin, that which can cause the cross sensitivity of the medication.
Before discharge, it is very important to provide health education to help the patient recover safely at home after a total knee replacement. The nurse should also advise on preparing the home environment, such as removing loose rugs, ensuring good lighting, and arranging for a caregiver or home health services if needed. First, regarding wound care and infection prevention, the patient must keep the surgical site clean and dry and change dressings as instructed. They should watch for signs such as redness, swelling, discharge, or fever and report them immediately. Scratching the wound or applying non-prescribed ointments should be avoided. Second, pain and medication management. Pain medicines should be taken as prescribed, not only when the pain worsens. The patient should not adjust their hypertension or prostate medications without medical advice, and supplements like glucosamine or vitamins should only be continued if approved by doctor. Third, mobility and physiotherapy. The patient should use a walker or cane until advised otherwise and avoid putting too much weight on the new knee. Daily physiotherapy exercises must be practiced at home to build strength and flexibility. Walking distance should be increased gradually, while prolonged standing should be avoided in the early recovery phase. Next is activity and lifestyle. High-impact activities like running or jumping should be avoided. Instead, the patient can do low-impact exercises such as walking or gentle cycling once cleared by the surgeon. Sitting in the chairs with arms makes it easier to stand, and elevating the leg can help if swelling occurs. For sleep and rest, the patient is advised to maintain a regular bedtime routine to reduce night wakings. Pillows may be used for leg support to achieve a comfortable sleeping position. In terms of nutrition and hydration, the diet should be balanced with adequate protein, calcium, and iron to support healing and blood recovery. Fluids should also be taken sufficiently unless restricted for medical reasons. Safety at home is also very important. The patient should keep frequently used items within easy reach, remove obstacles that may cause falls, and if necessary, install grab bars in the bathroom. Lastly, follow-up and reflex. All follow-up appointments with the surgeon and physiotherapist must be attended. The patient should seek immediate medical attention if they experience severe pain not relieved by medication, sudden swelling or redness in the leg, chest pain, shortness of breath, or signs of wound infection. Overall, this health education is essential to promote safe recovery, prevent complications, and help the patient return to daily life with improved function and quality of life.
In conclusion, from this case study, we learned about osteoarthritis and total knee replacement (TKR), including the causes, treatment, and the recovery process. We gained experience in managing a TKR patient, especially in providing nursing care and health education to support recovery. We also understood the treatment process of TKR and its post-operative care. By collecting the patient history, we was able to plan and apply an appropriate nursing care plan with suitable intervention. Overall, this case gave us valuable knowledge and skills that can be applied in the future nursing practice.